Welcome to EdHead's virtual deep brain stimulation surgery. My name is Dr. Vanessa Mai, and today I will be showing you the 5-step process of helping a patient with movement disorders. Are you ready? Our patient is a 59-year-old woman named Ellen, who is 5 feet 8 inches tall, weighs 120 pounds, and has suffered from Parkinson's disease for the last 20 years. Ellen is an attorney and cannot leave court to take pills every 2 hours, which is the only way to control the unwanted movements caused by the disease. Before recommending Ellen for surgery, her neurologist, Dr. Thompson, will need to get a clear idea of how the disease impacts Ellen. He has determined that prescription medication alone can no longer control her symptoms. Let's take a look at the severity of Ellen's tremors. Because Dr. Thompson can no longer control Ellen's movements with medication, he has recommended her for deep brain stimulation surgery. That's where we come in. You will be assisting me as resident surgeon to perform 3 of the 5 steps of this procedure. Dr. Thompson has already evaluated our patient, which is step 1. We'll handle step 2, putting in the fiducials, step 3, performing the brain surgery, and step 4, putting in the battery packs. Finally, the patient will return to the neurologist for step 5, activating and setting the system. To begin, fiducials, or screws, are put into the patient's skull to act as markers for the surgery. They need to go firmly into the skull since skin moves around. We can't base precise measurements off of something that moves. Fiducials are typically set several days before the surgery. 6 fiducials are needed for this procedure. 2 will go in the forehead, 2 above each ear, and 2 in the back of the head. Why are the fiducials placed where they are? Good job! First, we need to numb the areas with a local anesthesia so the patient won't feel this. Inject the 6 locations with the local. Pick up the scalpel and make a small incision where the fiducial will. Use a lap sponge to blot away the blood. Now use the screwdriver to put the fiducial into the skull. Now the patient will be sedated and undergo both a CT and MRI scan. These 2 scans will be used to build a very detailed 3-dimensional picture of the skull and brain. The fiducials you put in earlier will be used as highly accurate markers during the surgery. We will be using a global positioning system, GPS, which helps plan our surgical trajectory in advance. The computer will combine the images and help us locate the subthalamic nucleus, STN. Take a look at this image. We are targeting the subthalamic nucleus on both sides of the brain. Let's plan the trajectory for the first side. Select the color of the trajectory that you think would avoid the possibility of brain damage. Great job! This is a good trajectory to the target. It doesn't go through any sections of the brain that would be permanently damaged by the probe. Now we have mapped our trajectory to the target. It will be saved in the computer for the day of surgery. Alan has undergone all the pre-op testing of her general health and ability to tolerate surgery. She has been approved for the surgery. Alan has already been put on the operating room table, which places her in a reclined position while supporting her head and neck with a brace. She will be in a monitored anesthetic condition, which means she will be sleepy, relaxed, and maybe even a bit goofy, but she can be brought back quickly to a state of relative normalcy.
I smell daffodils.
A general anesthetic takes several hours to wear off, so we don't want to use that. We'll start by shaving her hair. Now that we've selected a safe trajectory on the monitor, we need to map the same trajectory to the patient's head. In order to do this, we'll use non-sterile probes to register the position of the fiducials with the GPS system. This information will be used to determine where to put the incision marks. The error is less than 1 millimeter, so we are in good shape. It's time to mark the scalp where we will make the incisions. We will make one mark on each side, since the left side of her brain controls the right side of her body, and the right side of her brain controls the left side of her. Great! Now we need to finish prepping the patient. The scalp has many sweat glands and grows a lot of bacteria, so scrubbing with betadine solution is important and has to be repeated several times. You do the first scrubbing with betadine. Make sure you get the whole scalp, and then I'll dry it with a sterile towel. I'll repeat these steps 2 more times. We need to inject a local anesthetic to make sure that the patient stays comfortable. Inject a local anesthetic around the head and where the incision will be. We will clean the scalp 2 more times using DuraPrep solution, making sure to scrub the fiducial. Now we will begin to establish the sterile field. We both need to change our gloves and put on sterile surgical gloves. From this point forward, anything touching the scalp must be sterile. We need to put sterile towels around the scalp to further protect the patient from infection. I'll hold the towels in place with IO-Ban, a betadine-infused sticky plastic. Next, we'll put a layer of IO-Ban over the whole scalp. Another large plastic drape is put over the scalp and shoulders. At this point, we do a final check of the identity of the patient, the procedure to be performed, and any information that needs to be transmitted to the team as a whole. Now we are ready to begin the surgery. Take the scalpel and make an incision where we marked earlier. Wow, your hands are as steady as a giant oak. Now use the Bovie, a cauterizing device, to stop the bleeding around the incisions. Take the drill and make 2 holes in the skull to expose our patient's brain. I'll use saline to wash the area while you're drilling. Why do you think I used a saline solution during drilling? No, not quite. Nice work. We will use a tower system to guide the placement of the recording electrode and, ultimately, the stimulation probe inside the brain. This tower system is called the frameless stereotaxis system. We will start by attaching the base of each tower to... I'll put the other base in place and then use 3 screws to make sure the base stays securely attached. Now, we want to make the final measurement of the fiducials and tower in relation to the computer scan. The error that the computer shows for all measurements has to be less than 1 millimeter for us to proceed. This makes absolutely certain that we are in the right place and will hit the right target when we insert the probes. Now let's adjust the tower base into a position that will allow us to follow our pre-planned route to the STN. We'll set a number on the tower to 10 millimeters less than the number indicated on the computer screen to make sure the probe is inserted the correct distance and so we don't overshoot the target. Why are we going to so much effort to measure and remeasure the location of the fiducials in the base of the tower? Try again. Awesome! Now we need to put the top of the tower on the base, which will guide the probe directly. The target for stimulation is the left subthalamic nucleus, which is part of the basal ganglia. Stimulating this area will help control the tremors caused by the disease. Believe it or not, in addition to the GPS, we actually use... If all goes well, we will first skim by the thalamus, hearing it as we go, then we'll pass through a quiet zone without neurons, and finally, we'll hear the firing noises the STN produces. We are ready to insert the recording probe. The probe should go in about 10 millimeters shy of the target using our tower measurements. This allows you to slowly advance the last 10 millimeters without making a hollow groove in the brain. Do you think you can identify the part of the brain from the sound? Go ahead and slowly insert the probe until you think you are in the subthalamic nucleus. When you are in what you think is the right place, you will then remove the recording probe and insert the stimulation probe. I think you hit the right spot. However, we need to test and make sure. There is a section of the brain very near the STN that is a sensory center. That means if we accidentally stimulate the sensory center instead of the STN, the patient will feel a tingling sensation in her hands and face or legs, and that's not good. A nurse will test the patient for hand-eye coordination, ability to perform fine motor functions, and also ability to move quickly and with control. Parkinson's patients not only have trouble moving the way they want, but also their muscles are often rigid, preventing them from moving freely, so we'll test for that too. Our patient is also asked to draw a straight line and to write her name. This is compared to what was drawn and written before surgery started.
Ellen, I need you to open your eyes for me. Great! Can you follow my finger with your eyes? Good! Touch the end of my finger with your right hand. Excellent! Hold both hands out straight for me. Great! There's no tremor now in your right hand. Now please tell me if you feel anything like a tingling sensation in your face or your right hand.
Only a little bit.
Okay, we just want to make sure that we aren't overstimulating the brain. Now I would like you to touch the first finger and thumb of your right hand together as fast as you can. Great! Now open and close your whole hand as fast as you can. You're doing very well. Touch the end of your nose. Now take this cup and pretend to drink from it.
So thirsty.
Now let's see if we can work with some numbers. Please count backwards from 100 in units of 7.
I couldn't do this before the surgery. Are you expecting me to now?
Just give it a try, Ellen.
100, 93, 86, 78? No, 79.
Excellent. Tell me, do you still feel the tingling in your face and hand?
No, it's gone away now.
Okay, one final test, Ellen. I'd like you to draw a straight line on the top half of this paper and write your signature in cursive on the bottom, just like you did before surgery.
Wow, you can actually read it this time.
Doctor, what do you think?
Ellen, we have the benefits we want here without the side effects, so we're going to sedate you a bit and then start working on the other side. Why doesn't the surgeon do the testing with the patient? Good job. You did really well with the placement of the probe. It sometimes takes several tries to get the placement that does the patient the maximum amount of good without causing side effects. Now that we've finished preliminary testing with the left side of Ellen's brain, we need to make absolutely certain that the probe doesn't move when we close her up. In order to do this, we will use this plastic piece called a Pac-Man to hold the probes in place. Put a Pac-Man piece in the drill hole on this side of the